Okay, we have a few people joining, but as we get going, I will kick us off. Just want to make sure that everyone joining us today is comfortable with the technical aspects of our webinar. As you see, closed captioning is enabled in today's webinar. We'll also have American Sign Language capabilities enabled in the meeting. You can activate this by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please go ahead and send a chat message to the hosts and we'll address it for you. Lastly, if you have questions during the presentation, please enter them into the Q&A area. The questions will be sent directly to the presentations and moderators, and we'll address them in real time or during the Q&A session. Next slide, please. We'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the U.S. Department of Health and Human Services and Substance Abuse and Mental Health Services Administration, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. SAMHSA has selected Altarum to provide training and technical assistance, support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix LLC, who have extensive experience with crisis services and technical assistance, the TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal of the crisis system TTAC is to support a crisis care system that's integrated, sustainable, and aligned with evidence-based and evidence-informed practices. We're going to provide you with the link in the chat here. If you have any technical assistance needs, we encourage you to go to the TTAC website and submit a TTAC request. Next slide, please. We'd like to thank the team at SAMHSA for supporting these efforts. Thanks to Jill Mays, the Division Director of Crisis System Transformation, and China Locklear, the Public Health Advisor at SAMHSA, for leading these efforts for the older adult workstream. Next slide, please. This webinar will focus on older adults in the crisis system and highlight a strategy for strengthening crisis response and follow-up care for older adults through cross-sector collaboration between healthcare providers and crisis lines. Participants will learn about the unique risks faced by older adults in crisis, the role of primary care in suicide prevention and follow-up, effective models for cross-sector collaboration, and practical tools and lessons from a successful implementation example. Next slide, please. Here's our agenda. We're going to spend most of our time focusing on an overview of older adults in the crisis system, and then an overview of the successful implementation of a program, and some follow-up time focusing on Q&A. As we noted, if you have questions throughout the webinar, please submit them through the Q&A, or please use the chat function as well. Next slide, please. Please just take a minute to complete this poll. We'd like to know who's in our audience. Go ahead and answer. What pillar of the crisis system do you work in, and what is your role? Okay, we got a bunch of answers coming in. Right, we got about 55% call center staff, about a quarter mobile crisis response, or about equally split stabilization center crisis response. And then for roles, let's see, we have a great split across social worker, case manager, community health worker, peer recovery specialists, therapists, state leadership, program manager. Great. All right, I'm going to go ahead and end the poll. Thank you for participating in that. Okay, next slide, please. Okay, we'd like to introduce our speakers. We have Dr. Anna Raslev. She's a national expert on collaborative care, specifically on training teams to implement and deliver mental health treatment in primary care settings. She has a passion for translating complex research ideas into practical real-world applications at the University of Washington. Next slide, please. She's joined by Dr. Anna Rodden. She's an epidemiologist and experienced public health leader and currently an applied research scientist at St. Luke's Health System in Idaho, where she's the principal investigator for 3 large-scale randomized controlled trials related to mental health and suicide prevention, funded by the Patient-Centered Outcomes Research Institute and the American Foundation for Suicide Prevention. And she is joined by Matt Biss, who is the project manager for the Idaho Crisis and Suicide Hotline Research Team, where he's currently the manager. Next slide, please. All right, I'm going to turn it over to our first speaker, Dr. Anna Raslev.
All right, very nice. Thank you for the invitation. I'm really pleased to be here and share some information to kind of set the stage for the great work that you're going to hear about from my colleagues who have been really thinking a lot about how do we intervene to support our patients out in our communities that are struggling with suicidal ideation. So I'll present an overview of older adults and maybe some opportunities that we have to actually intervene around older adults that may present in crisis. Let's go ahead and go to the next slide. So first, I want to just set the stage a little bit around older adults and suicide risk. I think there are a couple of things to think about when we think about this population. Although older adults have many strengths, there are some vulnerabilities in older adults that I think really put them at risk for being a high-risk population. So these include patients that may be experiencing psychiatric illness. There tends to be more physical illness and chronic pain in this population, which often is related to functional impairment. There may be cognitive impairments, including dementias and other neurocognitive disorders, as well as, I think, often a lot of stressors related to social isolation. Many times people are struggling with bereavement, loss of their communities and partners, and then perceived burdensomeness, which also seem to be risk factors for developing suicidal ideation. And it's important to think about this population because they have a fairly high prevalence of suicidal risk. Let's go ahead and go to the next slide. So what I want to talk about is maybe some of the opportunities we have to intervene. And one of the opportunities that I think is really important to focus on is the opportunities to engage patients in primary care settings. So this is important because we have data that show that a common place that people are going to show up for care or the opportunity to engage in care is primary care. So when you look at data related to people who have died by suicide, 83% of them have been seen by a primary medical provider within the past year. And nearly 50% of those have actually seen a primary care provider in the month before they died. And I think this is especially true for older adult populations that may be more likely actually to show up and present to care than some of our younger populations. So there's a lot more opportunity. They tend to have more interaction and dependency because they often are struggling with other physical health diagnoses as people age. So primary care is going to be a really important part of how we address these increased risks for suicidal ideation in older adults. Let's go ahead and go to the next slide. So I'm going to talk about sort of 3 buckets where I see there could be opportunities in primary care to really engage this population. The first is the concept that there's an opportunity for early detection of suicide risk. So Importantly, we do see increased risks for rates of screening for depression, and that is a recommendation of the U.S. Preventative Services Task Force that we do screen populations for depression. It's also something that is a common requirement for Medicare in their annual visit appointments. So many organizations are using either a PHQ-9 or a Patient Health Questionnaire 9 or a geriatric depression scale. Both of these scales are really good tools to potentially detect people at risk because they also screen for suicide. Both of those screeners have questions related to suicide. So, as we see increased risk rates of depression screening, there's really an opportunity to also detect more people that may be at risk for suicide. We can go ahead and go to the next point. The next thing is that there's a real opportunity to connect people to mental health services when they are identified through these detection mechanisms. And one of those opportunities would be the collaborative care model. There can be other integrated behavioral health services, and most primary care organizations, if they don't have a formal integrated care program, also have some systems in place to connect people to mental health services. So this can be a really important, that connection to engagement in treatment can be a really important strategy to address risk for suicide. And I will talk a little bit more about the collaborative care model on the next slide. We can go ahead and go to that. So I do want to introduce the collaborative care model. This is an evidence-based intervention in which there is a systematic way to deliver mental health services in primary care settings. This model has over 100 randomized controlled trials that have shown it to be effective. And the largest trial to date, which had 1,800 patients, was actually in older adults. So we know that this is also an effective strategy to address mental health treatment for older adults. This model is really based off of the idea that there's a primary care provider and a patient. That primary care provider is the medical home for that patient. And we add in additional resources of a behavioral health care manager. This is often a master's trained level behavioral health provider that supports that primary care provider, can provide direct patient care as well as care coordination, and then input from a psychiatric consultant. So this is a psychiatrist or nurse practitioner who provides expert consultation, mostly indirectly through consultation to that primary care provider and the primary care um, behavioral health care manager. When this model is delivered to fidelity, that includes use of measurement-based treatment to target and use of a registry. It can really help achieve the quintuple aim of healthcare reform, which includes better patient outcomes. These include reductions in suicidal ideation. So this may be a really important strategy to address the suicidal risk of older adults, reducing total costs of care. There is strong provider satisfaction compared to usual care. Patients really like care when it's delivered this way, and this includes older adult patients. And then it can reduce health disparities and stigma. Let's go ahead and go to the next slide. And then I think our last opportunity really in primary care is the opportunity to follow patients longitudinally. That medical home that often older adults are engaged in really allows you to be able to follow them longitudinally and connect them to crisis care when needed. And I think we'll hear in the next presentation an example of the kind of services that can be offered when you make those connections. And I think that is my last slide. So we can go to the next one. So this is my name and email address. I'm happy to connect if you have questions or response beyond the presentation. And we can go ahead and go, and I will let the other two presenters take it away.
Thanks so much, Anna. That was a really nice framing of the issue we'll be discussing today. And I'm going to present this section along with my colleague, the wonderful Matt Biss from the Idaho Crisis and Suicide Hotline. And together we'll be focused on discussing effective phone and text message-based follow-up care for suicide prevention. We'll do that by sharing insights and lessons we've learned from the Suicide Prevention Among Recipients of Care, or SPARK trial. And we'll share some new tools that we have developed that we think will support implementation if you all would like to try this out in your own organizations. Next slide, please. So just to start, we'd like to acknowledge that we have the privilege today of representing a really large team of folks that have contributed to this work, including our team at St. Luke's Health System in Idaho, the Idaho Crisis and Suicide Hotline, the University of Washington, our People with Lived Experience Advisory Board in Idaho that have advised this study from day one all the way through its completion and are now supporting us with dissemination work, and of course, our participants in the research. Next slide, please. The work we'll be presenting on today was funded by a grant from the Patient-Centered Outcomes Research Institute, or PCORI, and the ideas we're discussing today are our own, and we don't have any conflicts of interest to declare. Next slide, please. So I want to start by talking a little bit about the why for this work. Anna mentioned the potential for health systems to be engaged in screening for suicide risk, which I think is something that's happening at many health systems across the United States. And I can share a little bit from our experience at our health system. We screen universally at each of our 9 emergency departments. Every patient that comes in gets screened for suicide risk. Same at each of our 25 outpatient behavioral health clinics. And we're screening any patient at risk that's coming in with a behavioral health reason for visit in any of our 50+ primary care clinics. So you can imagine that we are identifying a large volume of patients who are in need support for their suicide risk right away. But Idaho, like many other states, faces a real shortage of mental health care clinicians that are available to provide that care. And so this means that our patients are facing long wait times to get connected to behavioral health care. As Anna mentioned, older adults are a population of special interest for us because they are more likely to seek care in primary care. And so we're identifying more and more older adults at risk for suicide and want to be sure that we are able to support them. The capacity to deliver long-term follow-up care through primary care is variable, and I think the word variable is probably generous here. It's really challenging. While we do have that long-term relationship, the ability to deliver 12 or more months of evidence-based follow-up support from that very busy clinical setting is challenging. And so we have developed a model that we think has a lot of potential in partnering with our state 988 crisis and suicide hotline. Next slide, please. We can keep going. I just want to give a little bit of background on our health systems partnership with our state crisis line. This is a model that is not entirely new. I'm sure a lot of crisis lines partner with, for example, EDs, emergency departments, to call and check in on patients that were discharged from the ED with suicide risk, but we're really envisioning a new model for longer term follow-up care. That's one person at the hotline that's checking in with patients identified at risk for suicide for at least 12 months. This longer term follow-up care using an evidence-based model has been proven to significantly reduce suicide risk and is something that can start right away, while patients would otherwise be waiting a long time potentially to get started with behavioral health care clinical support. We believe hotlines are optimally positioned to deliver long-term follow-up care for a number of reasons. First, they're already staffed with highly empathetic, well-trained crisis responders who are very comfortable discussing suicide risk and other crises that may arise with folks at risk for suicide. Being trained in crisis intervention is a plus because they're staffed 24/7. They're able to monitor incoming messages from folks that we're following up with at all hours of the day and night. The model, as I mentioned, we're interested in and we'll be discussing today involves assigning a single person that is assigned to each patient or each client to follow them up for that 12 months. And hotlines are already really well versed at doing safety planning and providing instrumental support, like connecting people with resources in their community that they may need to address risk factors contributing to their suicidality. So next slide, please. In order to start up a partnership between health systems and local crisis lines, the path probably looks a little bit different in every state and in every situation. But I wanted to share our path was pretty straightforward. So because we initiated this from the health system, we met with our hotline director who was really interested in partnering with us. We got our legal teams together, put some agreements in place, and we had a grant to support the work. So that's kind of how our system approached this. For crisis lines that are interested in initiating a partnership with healthcare, it's potentially more complex just because there are many different front doors to a health system. So I've listed in the box on the right side of the screen some of the different types of leaders that may make sense to engage with if hotlines are interested in starting that conversation with health systems. Next slide, please. We're going to pivot now to talk about the interventions that we used in our study. So two different models of follow-up care. The first one is called Instrumental Support Calls, or ISC. The second one is called Caring Contacts Text Messages. Next slide, please. So I'm going to talk first about instrumental support calls and what these involve. So everyone in our study that was randomized to receive instrumental support got a safety planning intervention plus instrumental support phone calls over up to 3 months. Some were allowed to continue longer if they wanted to, but this was generally between 1 and 6 phone calls from our team at the hotline. And the purpose of those calls was to review and revise the safety plan that they developed and make sure it was still practical and working well for them. Discuss and address any obstacles they may be facing to attending outpatient behavioral health treatment appointments, including things like psychological readiness or transportation or childcare. Um, uh, Also working to connect them with resources that may be helpful to address risk factors if they were facing financial insecurity or food insecurity or housing insecurity, we would support that as well. Patients were allowed to opt out of additional phone calls or request additional phone calls beyond the 6 standard calls. Next slide, please. This slide shows the standard schedule for those calls. So when we made them, generally day 3, 7, 14, 30, 60, and 90. So you can see a little more concentrated at the beginning and then tapering off. We allowed modifications to the schedule based on weekends, holidays, or when the participant wanted to have the phone calls. And once the participant felt like they'd had enough support, then we stopped the calls and they could ask for more support if they wanted additional phone calls too. Next slide, please. This slide summarizes a randomized controlled trial published by Stanley and Brown in JAMA Psychiatry in 2018, and they compared patients who received usual care to those that received the safety planning intervention plus these instrumental support follow-up calls. And they found that those receiving the phone calls were half as likely to engage in suicidal behavior and twice as likely to attend their outpatient behavioral health treatment appointments. Next slide, please. Now I'm going to pivot to the second follow-up care model that we discussed or that we'll be discussing today, and that's caring contacts. So everyone that received caring contacts was offered an initial phone call with their follow-up specialist to develop rapport and connection and get to know each other a little bit before that follow-up specialist started sending out text messages. So the follow-up specialist would then send out a series of 25 caring text messages over 12 months. These came more frequently at the beginning of the intervention and tapered off towards the end of that 12-month period. If the participant responded, then the follow-up specialist would text back and forth with them. So it has potential to be interactive, but people could also just passively receive the text messages if they didn't feel like responding. An example of the text exchange is here on the right side of the screen. Let's go to the next slide, please. There are 4 core principles to the caring contacts intervention. When we talk about caring contacts, we're talking about capital C, caring contacts. So the model that was developed by Dr. Jerome Motto in the 1970s. And he sent a series of letters to patients at risk for suicide that were unwilling to continue engaging in healthcare. His letters and his 4 principles underlying those letters were that they be non-demanding. This is maybe the least intuitive piece, but he felt it was really important not to ask anything of patients, to express care, unconditional care and interest without asking the patient to do anything. So we're not sending appointment reminders. We're not asking them if they made it to their treatment appointments. We're not asking them to do anything really. We're just sending them messages, letting them know that we care for them unconditionally and are interested in their well-being. Especially in the age of AI, that third core principle becomes really important to make sure that these messages appear as authentic and human as possible so that people don't perceive that these were just sent by a machine and don't really have a caring person behind them. And then the last piece is that caring contacts, in order to adhere to this model, need to be sent over the long term, so at least 12 or more months. And we found in clinical trials that really that's the time point when you start to see the biggest impact of this intervention is towards that 12-month time point. Next slide, please. So this is our schedule for when we sent out caring contacts text messages over 12 months. So we sent 3 in the first week, 6 weekly, 6 biweekly, 4 monthly, and 2 bi-monthly. And then we also layered in some holiday texts, which are on the right side of the slide there. We allowed our follow-up specialists were able to modify the schedule and the content of the messages so that it made sense and flowed with the conversation they were having with the participant. But we did make a point to try to send out any outgoing messages Monday through Friday during working hours when Matt and his team were actually in the office so that they could respond if someone texted back. Next slide, please. So these are a couple of examples. At the top, you've got outgoing caring contacts. So here's a couple example of non-demanding messages. I just wanted to say hello, and I hope you experience kindness today. And another example might be something like, hey, Sam, I'm glad we're in touch. If it ever helps to share how you're doing, I'm just a text away. So you notice we're not asking Sam how she's doing. We're not asking her to text us back or saying, I want to know how you are. We're just putting it out there that we care about her. And if it's helpful to her to let us know, then we are inviting that interaction. The tailored responses to participants. So this is just an example to show that we were able to really individualize the responses based on what we know about participants. And having that initial phone call really helps here. So this one was to Josie, and it says, thanks, Josie. The sunshine has been nice today. I hope you heal quickly after your surgery. I know you have a lot of support between your family, your church family, and your sweet dog. Just know I'll be thinking of you next week, and I'm also here if you need any extra support. And then replies from participants. We got a real range of replies, which Matt will present on a little bit later. But here are a couple. One person says, oh, thanks. Things are better than they were, but I've got a rough week ahead with work and family stuff. Someone else says, thank you for checking on me. I thought it would be awkward sharing with you, but it has been nice. I'm sure more people would benefit from quick check-ins like this. Next slide, please. So Caring Contacts also has an established evidence base, and the data on this slide are from a trial that Kate Comtois and her team did in 2019. It was published in JAMA Psychiatry. They found that compared to patients receiving usual care, those who received this two-way Caring Contacts text message intervention were 44% less likely to have suicidal thoughts and 48% less likely to attempt suicide. Next slide, please. So we've got these two great models of follow-up care, and we know that these can be life-saving interventions, but no one has ever looked directly to compare the two to see which one works best. And so that's why we designed the SPARK trial. Our research question was which brief contact intervention works best to reduce suicidal ideation and behavior for adolescents and adults who screen at risk for suicide. Next slide, please. So our two treatment conditions were everybody in the study got a safety plan, and then people were randomized to receive either the instrumental support phone calls or the Caring Contacts text messages. As a reminder, the instrumental support phone calls are really focused on problem solving, getting participants connected with treatment and dealing really directly with their suicide risk. While the Caring Contacts text messages are focused on connection, listening, and caring for the participant. Next slide, please. So SPARK was a pragmatic comparative effectiveness randomized clinical trial, which is a mouthful. Really what this means is that the interventions were delivered by a team of non-clinicians at the 988 Crisis and Suicide Hotline. That's the pragmatic piece. We wanted to test a model for intervention delivery that would be feasible to do at scale and wouldn't be held back by some of the limitations we see in our state today based on the shortage of mental health care providers. So we also allowed a lot of flexibility in how those interventions were delivered. So we allowed patients or recipients of those interventions to say, that's enough support, I'm good now, or I actually need more than that. Can you call me more frequently? Can you text me? I'm going to text you because I need more support, that kind of thing. And then we also have, because it's a comparative effectiveness trial, 2 active treatment conditions. So often when people hear the words randomized clinical trial, they're thinking about a trial with a placebo or a control group. This study didn't have any control conditions. So we're testing 2 interventions that we know work, we know are effective, and comparing them head to head to see which one works best. That's important when we look at the results of the study, just to understand that the magnitude of difference between 2 very good interventions is going to be small, and a small difference may still be meaningful. So just wanted to flag that. The SPARK trial enrolled a total of 1,520 patients in primary care or emergency department settings who screened at risk for suicide. This included 797 adults between the ages of 18 and 93, and 723 adolescents between the ages of 12 and 17. And next slide, please. There are a couple of things that are innovative about Spark, this trial, our setting, and our population. So first, the fact that we did this work in Idaho meant that we're representing one of the states with the highest suicide rates in the United States, and 8 of the 10 states with the highest suicide rates are in the Intermountain West region. But there's very little research that comes out of this part of the country because it tends to be under-resourced, more rural, and not have the large academic centers that are more prevalent on the coast than in larger cities. Including a rural and frontier population in this study was important as well, because we know that residents of rural areas face a disproportionately high burden of suicide risk compared to those in cities. And also, most of the data and all of the trials published on the 2 interventions, the 2 types of follow-up care that have been published so far, were done in VA or Department of Defense settings, so with veterans or active duty service members. This was the first large-scale trial to include a civilian population, meaning it's the first that includes older adults. It's women were better represented in our study, and it was also the first study to include a large sample of adolescents, which were excluded from all the other trials. And then lastly, we deliberately recruited patients with the full spectrum of suicide risk, from low levels of passive suicidal ideation all the way up to acute suicidal crisis, from both primary care and emergency department settings. And typically in suicide prevention research, patients are recruited if they've had a suicide risk incident, like a suicide attempt previously. So this was novel to include such a broad spectrum of risk in our study. Next slide, please. One of the other things that was novel about this work and really strengthened the research was the inclusion of a lived experience with suicide advisory board. We had a team of 15 community members who have lived experience with suicide that were engaged from the very beginning when we first came up with the idea to do this study, all the way to now when we're disseminating the results. And these folks gave us such good feedback all along the way. Matt was part of this original team before he shifted over and became our program manager for the study. But I can't emphasize enough how much good feedback we've received from these folks. And I want to share just one example of feedback from our lived experience advisors. We were planning to include automated replies that would show up if someone texted in after hours when Matt and his team were not available to respond. We didn't like the idea that someone could text in saying, I need help, and have nobody respond to them. So that's why we thought an auto reply would be a nice solution. But our lived experience advisors really did not like that. They thought it felt like something that we would put in place to make ourselves feel better, but that it wouldn't actually make patients feel more cared for. And I remember someone during the meeting asking, have you ever put up an auto reply for a friend who's suicidal because they might text you in the middle of the night? Probably not. They said it feels more human. They know that it's one person. They know when that person works, and they know that they're not up all night at work on their computer waiting for a text to come in. So we thought about this and were able to work with our legal and compliance teams to find a way for the hotline team outside of Matt and his immediate folks that are supporting our project to be able to monitor incoming text messages 24/7. It happened very rarely that someone texted in the middle of the night in acute suicidal crisis. And so Matt only actually got woken up a handful of times over 12 months with 1,500 participants at risk for suicide. So it was really good feedback from the board that I think enhanced the patient experience in the study and did not increase risk to our participants at all. Next slide, please. So I'm going to pivot now and report the results of the study. So I'm going to start with the results in adults. We found that in our adult participants, the instrumental support phone calls were significantly more effective than the caring contacts text messages at 6 months. There was a small but significant difference in suicide risk score, which is our primary outcome, and in loneliness at that time point. So you can see the graph at the right side of this slide shows the difference between, you can see where those two lines start to diverge with the folks receiving the text messages being the solid line on top, that their suicide risk declined more slowly. And at 6 months, there's a meaningful difference between those two lines showing that the people receiving the phone calls were doing better in terms of their overall suicide risk at 6 months. By 12 months, the two treatments were equally effective. So the caring contacts folks did catch up by 12 months. And there was no difference at either time point in suicide attempts based on treatment condition in adults. Next slide, please. This slide shows the results in our adolescents between the ages of 12 and 17. So interestingly, the results are sort of flipped for this population. We found that in teens, instrumental support calls and caring contacts texts were equally effective at the 6-month time point, but by 12 months, you can see those lines start to separate. And we found a small but significant and clinically important difference in suicide risk score. So at the 12-month time point. Next slide, please. And one of the most important findings in adolescence was that we found between months 6 to 12, there were 2.5 times fewer suicide attempts reported in teens receiving caring contacts compared to teens that received instrumental support phone calls. Next slide, please. So just to summarize the results, this is a comparative effectiveness trial, so we don't have that overall how impactful were either of these treatments, but we can see really clearly that suicidal ideation and behavior were significantly reduced in both treatment conditions in our adults and in our teens. We also note that the results are different for adolescents and for adults. We also looked at subgroups to see whether older adults had different results than younger adults or middle-aged adults and found no differences in the adult age group as a total. So the older adults looked similarly to the younger adults. This is also the first time that these two follow-up care models have been delivered by trained 988 responders, and this model was really successful. We're really proud of the results, and we think this has potential for tremendous potential for scalability and reach. Next slide, please. So this slide has some quotes from our participants, and we have hundreds of these because people were texting us in and filling out surveys, but just hundreds and hundreds of really positive bits of feedback from our participant. I won't read all of these, but I'll read a couple. One person said, "Thank you for everything. Seriously, you saved my life. You made me laugh when I didn't know what happy was. You talked me through some of the hardest things I've ever experienced, and I can't ever repay you except to say thank you. Thank you a million times." One of our older adults says, "I think I talk to you because you don't panic when I'm struggling. I can't be honest anywhere else. Thank you for being that place for me." Someone else says, "It's hard to reach out for help. It's nice having someone reach out to me." And then lastly, "That text actually meant the world to me." Next slide, please. So here we're going to transition. Matt is going to share some of his experience as the person actually sending and receiving these messages and making the phone calls. So over to you, Matt. Oh, you're muted, Matt.
I get that every time. It's a little button. Uh, my name is Matt again, and I lead a small team of follow-up specialists for the Idaho Crisis and Suicide Hotline, where we've been delivering the interventions that Dr. Radin and her team have designed for several research trials, including Spark. And I want to start off the top just by saying that I consider myself very fortunate to be part of this work. And I think I speak for our whole team when I say that it's made a big impact on our community, our hotline, and each of us as individuals. Um, Getting support is hard, and I don't think there's anyone here that would disagree with that sentiment. Our healthcare system has been doing a great job at identifying patients that are at risk of suicide. We identify them, but then what happens? As Anna said, unfortunately, there's a shortage of resources available. I'm sure many of you are experiencing the same obstacles. And even when resources are available, healing can take a lot of time. So, one of the things I love about the work that we're doing is our reach. During Spark, we aim to meet people where they were at. And for pretty much everyone, where they're at is on their cell phones. And I know that that's true. I bet there's a substantial portion of you that are looking at your phones right now. And if that's you, what do you see there? Is it stress? Are you doom scrolling? Is it a busy schedule? Work emails? Like, what if instead of that, it was a caring, supportive person that is there for you when you need them? When our help seekers are in that moment of crisis, we don't want them to wait until their next counseling appointment when what they really need is some support right now. And a lot of us are in these crisis services for right now kind of help. And those services are vital in moments like these. But what we learned in Spark is that we can be very proactive in our follow-up care, utilizing programs that fit in seamlessly with the rest of someone's treatment plan, filling those gaps in between with something that's minimally invasive. Slide, please. So I'd like to introduce you to a Spark participant, or a Sparky, as we call them, and illustrate how this works. Mindy is an older woman. She has some complex health issues, and she struggles with suicide mainly as a way to end her pain. Now, Mindy's been doing all the things that she's supposed to do, jumping through all the hoops, all the red tape. But, as we all understand, sometimes the health system wheels turn slowly, and people like Mindy are often left waiting their turn to get some help. But Mindy wasn't alone. She had Hannah as her follow-up specialist. And I'll tell you what, she's great. I wish everyone could have their own Hannah. But you don't have to take my word for it. Here's what Mindy said about Hannah. I've been so patient and tried to get help, and Hannah is the only person who actually listened. Slide. So one day Mindy texts Hannah and says, I'm feeling completely invisible to the people other than you that are supposed to help me. I'm sure I've said it before, but this system is not very helpful and it's completely crazy. And Hannah responds, validating Mindy's feelings, letting her know she's cared about and she has support. And after all, isn't that exactly what Mindy was just telling us that she needs? She wants to feel listened to and cared about and be supported. And Hannah says, it's awful that you're being put off. It shouldn't be this hard for you to get help. It's heartbreaking, and you must be immensely frustrated. Slide, please. So their conversation continues, and over the course of it, Mindy had revealed that her thoughts of suicide were escalating, and she was becoming fixated with overdosing on her medication. And really, it was just after all of her struggles, she wanted to give up. But Hannah took the time to call her. She used her crisis intervention skills to help Mindy back to safety and even helped her find a support group. So keep in mind that the messages that we send, they're not just a reminder that someone out there cares about you, but they're also an invitation to share their struggles and be heard. So let's introduce you to one more participant. And just to give you a little variety, we'll take a young person. Meet Sam. I love Sam. Sam is a teenager living in a small mountain town in Idaho. And I texted regularly with him for a year during the Spark trial. We spoke on the phone a few times. I love this kid. He has a great big heart. He cares tremendously about everyone on this planet. He once told me that if he had one wish, it would be that all of us be kind to one another. Now, Sam's lucky in some regards because his family's really supportive. They spend a lot of time and resources to get him to ongoing treatment and help when he needs it, and they're happy to do so. But that help, because of his location, it's usually hours away, and he feels very guilty about being a burden to his family. And this is the type of conversation that we had many times. Slide, please. So one night, Sam was struggling in silence, and he was preparing to end his life. And he couldn't bring himself to ask his parents for help yet again. And he genuinely felt like they would be better off without him being a burden. And then he texted me. He said, "I don't feel safe, but I don't want to tell anyone." Well, he told me. Sam reached out to me in this moment of crisis, and we exchanged some texts for quite a while. We worked through a safety plan, talked about his options, and in the end, we both agreed that if Sam was going to be safe that night, he really does need to talk to his parents. But because of Spark, he didn't have to do it alone. I spoke to his mother for him, and together we developed a plan that would support Sam and get him some additional help. And last I heard, Sam is off in college and doing well. Slide, please. So this model, it works well because, as I keep saying, it allows us to reach people where they're at, specifically when they need it, and in a low pressure environment. The way that we're engaging with these patients or participants is different than the other types of support that they receive. This is a different role than other healthcare helpers. What we're offering is trained but non-clinical support. And really, it works just via the magic of human connection. As Anna said, our follow-up specialists came from our state suicide hotline. And kind of how it goes when a new participant is referred by their doctor and they enroll, um, they're assigned a single follow-up specialist that they talk to for a year. We'd have their background, their basic medical records, suicide screenings, stuff like that. And then no matter which track they were on, we'd start off our year together with a quick get to know you call. And then we do our thing for a year. We check in, we provide support, we help them find resources, and most importantly, we let them know that we're there and that we care about them. If we're unsure about their safety, we check on them. Slide, please. We learned a lot in Spark, and we can't fit everything in here. So Anna will be telling you a little more later about our toolkit, which we're very happy about. We don't believe that any organization that wants to launch their own program like this should have to start from scratch. But before we get to that, just a few things I'd like to highlight. So our Spark participants were varied, young, old. They came from a variety of healthcare providers and settings, at a wide range of risk levels. And that means that everyone coming in wasn't at the same place psychologically. Some already had treatment in place, and others had significant obstacles to care. And that might just simply be not being ready to try a new medication, or they're not sure if they want to talk to a psychiatrist, for example. But no matter where they were, their follow-up specialist is there with them for a year plus to support them and help them work through some of this. Another thing that we learned, probably to the surprise of no one, is that the generational divide is real. For example, teens tend to prefer texting, and they have very high expectations of prompt replies. They they know that you've got a phone, so why haven't you texted back yet? Whereas our older adults, more seasoned, they have more patience. They tend to prefer the personal touch of a phone call, even if they were on the texting intervention. um, so while the data does show there's some differences between age groups, and that may inform kind of how we design these programs, I think the real lesson, though, is just try not to make assumptions and treat everyone as an individual. And as we mentioned, our initial caring contact message that we send, it's meant to be non-demanding. One thing we quickly learned is that those who do reply, they wanted us to engage them more, to in fact be more demanding. So once they've accepted that invitation and they talk back, they want us to ask questions and engage them, just like a friend would, or a peer support, or anyone that's in another helping role would do. Another thing that we learned, it's critical to be authentic. And I'll say that if you are real with them, no AI can ever replace you. It's a matter of not even acting like you care. You should actually care. And I think I'm preaching to the choir here. But just keep that in mind. People will feel the authenticity if it's there. Another thing that we learned and we're a little concerned about is that when you're sending caring contacts, there's always going to be some folks that don't reply to you. And while we knew that would happen when you're the one sending them and you don't know if they're not replying, like, ever. What does that mean? Is it not working? Do they not like me? Well, it turns out that's actually okay. That's just fine. Our non-repliers still had fewer suicide attempts. They had reduced suicidal ideation. And we were told over and over again that even though they didn't say anything back, they found the program very helpful. And then finally, after a few variations of this, multiple trials that we've done, the team's overall favorite version of this is a two-way caring contacts model. A two-way meaning I text you and you can text me back, versus a one-way, which is I text you, you can't text me back. We like the two-way version with an optional phone call introduction to introduce them to their follow-up specialist. Go ahead, please. Now, older adults are not just, big kids. So let's talk about a few special considerations. As I said, we found that our older population was more likely to ask for phone calls, even if they were on a text messaging intervention. But I want you to take a moment to think about the older adults in your own lives. We tend to think of the negatives when it comes to aging. and often overlook some of those positive aspects. Accumulated life experience can provide us wisdom, problem-solving abilities. We tend to develop greater understanding of ourselves and our emotions as we age. We hopefully learn some resilience and self-acceptance. And another thing is that older adults can be better at prioritizing what matters. So when we think about the older adult who hopefully we will all one day be, we're thinking about someone who may have spent their entire life contributing to society, learning, becoming all the things that I just said, only to reach a point where they need a little help. And so maybe they've always been the rock that their family relied on, or maybe they have no family, or maybe they simply don't want to be a burden to their family. There's a lot of valid reasons that someone may find it hard to ask for help. And that's why it's so important that we meet them where they're at to extend a hand. We lower the burden of getting help when we're there proactively, letting them know that it's okay and that this is a safe place, a safe person to ask for help. I often say that what we're doing is long-term crisis care with cheat codes. And it's because we're able to connect with someone for so long and we get to learn a lot about them. And so I would say that, use that to their advantage and tailor your communication to your audience. Go ahead, please. Real quick, I wanted to show you just a piece of a storyline. And if it wasn't clear, when I say caring context, I'm referring to our 25 planned messages that are scheduled throughout the year. And we'll call the entire set of these a storyline. And so we have that first message there on day one. And then there are more messages in the beginning, and they kind of taper off over the year. And these messages, they're carefully crafted to fit our model, to be caring, but non-demanding. And there's kind of a balance. We found it was actually kind of tricky to write these to hit just the right tone. That's different than our replies to their responses, where we get to be authentic and engage with them fully, just like a real person would, and we're real people, right? So what kind of replies are we getting? Slide, please. So for our caring contacts participants, we texted them with a baseline of 25 times, and then they texted back an average of 31 times. So most often the response that you're going to get to a caring contact is something along the lines of "thank you." And often our participants would be sharing the good things that happened in their lives. And you'll see there's a little slice on there for scheduling. Since we tended to have that introduction phone call with everyone, it's got its own little chunk on the pie. But then the rest of that are participants who told us that they were in need of varying levels of support. And that could be anywhere from, non-suicidal distress to an active suicidal crisis. I couldn't tell you how often participants replied to us, telling us, this message came at just the right moment. I had 2 of those this morning and last night. Or how many replied to a caring contact letting us know that they needed help, enabling us to de-escalate or help them find resources or lend a listening ear when they needed it most. And those are interactions and, slices of support that probably wouldn't have occurred without these programs in place. Okay, next slide, please. So let's switch back. We'll talk about phone calls for a moment. Before Spark, like I said, our team is made up of crisis responders from our hotline. And so we were already making follow-up calls as part of our regular duties, like I'm sure many of you do. And having done both our standard hotline follow-up and instrumental support calls for Spark. I would say that the latter is a huge improvement. When our team made follow-up calls for Spark, it was the same follow-up specialist reaching out each time. They built rapport, they learned the help seeker story, they had quite a bit of background information to help them with that. And that, that lets us know what kind of support to give and what questions to ask. If they didn't already have a safety plan, we made one with them or updated it with them. We helped them find local resources and we helped them overcome obstacles to care. And for example, one thing I like to point out is that we talked to every participant about 988, and overwhelmingly, the participants expressed existing concerns about privacy and their fear of police showing up at their door if they called 988. Well, our team was able to address those concerns right out of the gate. And then also explained that we, in fact, are responders for our local hotline. And if you call them, you'll be talking to someone that's just like us in a very similar fashion. And that reduced their fears about using that service substantially. And from the perspective of our older population, having someone here who's walking them through this system, holding their hand all the way through for a year, this feels like a premium white glove service with their own crisis concierge. It can be pretty special. Slide, please. I know you might be thinking, surely, Matt, this level of care for this many people, it must cost a fortune, and you must have a huge team. And I would tell you that you'd be wrong. We actually had other caring context research trials overlapping with this one, as well as a non-research program running alongside it. And while the research trials, because of all the extra steps we have to take, are more demanding on our time, at our peak, we handled that workload with 3 to 4 FTEs. People have been very surprised by our staffing recommendations for this, but we can give them because this is actually what happened with our team. And I don't want to, well, we don't really have time to get into operational details here, but again, I'll mention that toolkit that Anna's going to go into. And also, I'm happy to talk to anyone after we're done here if you have questions. And I would like to emphasize, another time that there's huge advantages to this hotline partnership. As we mentioned, 24/7 monitoring was a big help. Our team, we covered for each other, but if it's the middle of the night or the weekend, the supervisor in our hotline's phone room has an eye on all incoming messages. And so if a participant texted in, to their follow-up specialist that they're in trouble and they need support, they were able to quickly react to the situation. And it actually was a very rare event. It was not as big of a concern as we thought it would be. Slide, please. And finally, I think I want to wrap up my piece here just by emphasizing the importance of collaboration and working together. We have a regional health system that's fantastic. They're a fantastic research team, and our state 988 crisis line that worked together, improving patient outcomes. And I think there's magic in that sauce. Historically, these interventions were performed by providers and their staff, but as a shortage of that kind of clinical support is one of the problems that we're aiming to solve, another solution was needed, and enter the hotline. I'll emphasize one more time that I think crisis line workers are ideal for this. Suicide and crisis is our day-to-day, and were comfortable discussing these topics, and that actually put the Spark participants at ease. Um, and follow-up care is standard for the work that we do. And just from our team's perspective, we really like doing follow-ups this way. It's been very effective, and we legitimately, genuinely enjoy it. And so finally, I'll just sign off here by saying I think that this model of partnership can work very well. And with that, I will kick it back over to Anna. And thank you.
Thanks so much, Matt. That was great. All right, this is the final section of our presentation. We're just going to talk a little bit about translating this research into practice and some of the work we have underway. We've divided our dissemination and implementation work into three kind of buckets. The first is around investigation. So these are work that we're doing related to answering remaining questions about caring contacts and instrumental support calls and how to do follow-up care well. The second is around supporting others to scale up the interventions. So we're developing trainings, tools, and sample workflows that will support adoption of these follow-up care models in other settings outside of our own. And then lastly, our work in engagement is focused on building up stakeholder support to implement the interventions. Next slide, please. So starting with investigation, there are a couple of remaining questions that are still important related to operational things. So first, Matt brought up the question of cost, how much it costs to set up and run a caring contacts program. We've done some initial work with a health economist on this and have included our staffing and cost projections in our caring contacts toolkit, which I'll share in just a moment. We're also planning some more formal cost effectiveness evaluation. That research has been funded by the St. Luke's Foundation and will take place sometime kind of midsummer next year. We're waiting on the results from an ongoing trial, which is the next bullet on this slide. That's the spring trial, and it's funded by the American Foundation for Suicide Prevention. This trial is specifically designed to answer the question of if it matters whether you can reply to the caring contacts text messages. So in practice, a lot of folks have been sending out caring contacts texts without allowing participants to respond back. So they're one-way messages going out. That, as you can imagine, is operationally pretty simple. Compared to the two-way texting model that Matt and his team ran for us during the Spark trial. So we're in the spring trial directly comparing two-way texting versus one-way texting versus the usual care condition to see which is most effective, and we'll use those data to develop our cost effectiveness estimates. Next slide, please. Matt and I have alluded several times to an implementation toolkit. This is what it looks like on the right side of the screen, and we'll have a QR code at the end of the presentation where folks can get the link to download that. If someone wants to put the link in the chat now, that would be great too. But this is a 63-page practical guide we developed on how to stand up and deliver a caring contacts text message program and follow-up phone calls. So kind of the two models we just presented on. Our target audience for this is really folks like those of you on the call today. So 988 hotlines, health systems, primary care folks, hospitals, and others that want to deliver this kind of evidence-based follow-up care to their patients. Next slide, please. The Caring Contacts Toolkit is designed to help you all save time with ready-to-use templates and resources. It includes sample workflows, SOPs, caring contacts text messages that you can modify for your population, and then links to more information on this intervention and follow-up care in general. So there's a companion website developed by the University of Washington, St. Luke's, and our crisis hotline with more background on caring contacts, alternative models like using postal mail to send postcards if two-way texting isn't quite right, and additional resources. So there's just a lot of really good stuff in here that we hope folks will find helpful if they want to stand up a follow-up care program for clients that call into the hotline or for patients identified at risk at a health system. Next slide, please. We also have been working with the texting platform and calling platform that we used for the study, which is called Mosio, just to really optimize that platform to make it as easy as possible to deliver text messages and track messages for thousands of participants at once. So this is now, we're really happy with how it's turned out. It's HIPAA compliant. It's a great texting platform that now has been really kind of specifically designed for delivery of two-way hearing contacts. Next slide, please. We've also developed a user guide as a companion to that resource that is specifically includes workflows and how to set up your Mosio build. It includes step-by-step walkthrough and a number of tips that we think are helpful based on our experience. So that's also available on the website. Matt posted to the chat. Next slide, please. And finally, we really want to return the results of this trial to our participants. So we're working on developing a podcast that will summarize the results of the Spark trial and get those out to the people that were part of the trial, which includes our participants, but also our partners in our clinics, EDs, and communities. Next slide, please. So with that, here's the QR code for everyone, as well as the website. Our contact information, if you reach out to spark@slhs.org, that's SPARC@slhs.org, our team will get back to you, but we would love to connect if anyone has questions after this. So I think we can wrap up there. I'll pass it back to Taryn.
Thank you. Thank you so much. This was such a wonderful presentation.